Hi, my name is Dr. Tony Lang from the University of Toronto, and my job today is to give you a lecture on the introduction to multiple system atrophy, highlighting clinical features, how we make a diagnosis, and the underlying pathology. I have a number of disclosures. Some of them are becoming relevant to this area, so fortunately we are seeing an interest in the part of some pharmaceutical companies to develop treatments, and that's going to be very, very important in terms of changing the course of the disease that I'm going to tell you about this morning. Multiple system atrophy is what we call a synucleinopathy, a long name that emphasizes the presence of a protein, alpha-synuclein, which is a normal protein in the nervous system that, for reasons that we don't fully understand, deposits and aggregates in a group of disorders, including Parkinson's disease, dementia with Lewy bodies, pure autonomic failure, and multiple system atrophy. Lewy bodies are little inclusions that occur in nerve cells, and Parkinson's and dementia with Lewy bodies have these. Multiple system atrophy generally does not. And there are a number of other disorders that may have some Lewy bodies deposited as well. Now, alpha-synuclein is a normal protein that becomes abnormal in these conditions. And this is a nerve cell that projects a long axon that then talks to other nerve cells at the terminals of the axon. And alpha-synuclein sits in the terminal. This is a terminal that is before a synapse. Nerve cells talk to one another at synapses by releasing neurotransmitters, which are exemplified here in these little red dots. And alpha-synuclein, the little purple dots in this cartoon, have an important role in packaging the transmitter. For example, if this is dopamine, alpha-synuclein helps package the dopamine into what are called vesicles. It encourages the vesicles to come to the end of the terminus and release the dopamine, and then take up the dopamine and repackage the dopamine back into these vesicles. And so normally alpha-synuclein has an important role to play in synaptic function. Now, multiple system atrophy. Let's go through the clinical features of this disorder that was divided into a number of conditions. And this list here shows you that previous terms were applied: olivopontocerebellar atrophy, progressive autonomic failure, and idiopathic orthostatic hypotension. I'll define these for you in a minute. A disorder that was described at the Mayo Clinic by Schei and Drager, the Schei-Drager syndrome, and a disorder called striatonigral degeneration. So these disorders were all thought to be different until 1969, when Graham and Oppenheimer recognized similarities in their pathology and proposed that these be considered the same disorder, all variants of the same disorder. It wasn't until about 20 years later, Papp and Lantos and others found under the microscope these entities called gliocytoplasmic inclusions, and I'll show you these later in the talk. And these little inclusions in cells characterized all of these disorders and really confirmed Graham and Oppenheimer's suspicions that we were dealing with a single disorder. A little less than 10 years later, it was recognized that that protein, alpha-synuclein, was the dominant protein that accounted for these GCIs, or little inclusions. And this was defined on staining under the microscope with antibodies against alpha-synuclein. This is a relatively uncommon disorder, occurring in 1.9 to 4.4 people per 100,000. And if we look at it in an annual incidence, how many people are seen in 1 year, 0.6 new cases per 100,000 persons, or 3.0 in 100,000 over the age of 50. The cause or etiology is not known. There have been a number of studies to suggest that exposures to certain things in the environment, like solvents, pesticides, additives, metals, agricultural work, might all be associated, but there's very little strong supportive evidence for these relationships. Parkinson's disease is less common in smokers, and so this inverse association has also been described with multiple system atrophy, but it's probably not as strong. This is not a genetic disorder, as I'll emphasize later. There is not a strong genetic pattern. It's not something that we see from one generation to another. But in Asians, especially in Japan, the form that is called MSA-C, the cerebellar form that I'm going to define in a minute, is far more common than the Parkinsonian form. And so this suggests that maybe genetic factors play a role, for example, in Asian individuals. Now, the clinical characteristics are subdivided into three major subtypes or forms. Parkinsonism is a syndrome or an umbrella term that we use to describe the features that we more commonly see in Parkinson's disease, with slowness of movement, so-called bradykinesia, or increase in tone, rigidity, tendency to fall and poor postural stability, all features that make up that umbrella term Parkinsonism. Unlike Parkinson's disease, the tremor at rest is far less common. So you've probably seen patients with a shake of their hand when they're resting it in Parkinson's disease. Instead, in multiple system atrophy, patients will show or can show in about 50% a jerky tremor when they use the limb, when they're holding the limb out or when they're moving. And that's different from the typical resting tremor of Parkinson's disease. So Parkinsonism or MSAP is one form. The second commonest form is MSAC or cerebellar disorders. And when the back part of the brain, the cerebellum, is involved with disease, we see clinical features that we call ataxia, or clumsiness or incoordination of the limbs, of walking, of speech, and of the way we move our eyes. And so these features are all hallmarks of the MSAC or cerebellar ataxic form. Manifestations that are common to both of these features are related to damage of the autonomic nervous system. The autonomic nervous system is the part of the brain and the central and peripheral nervous system that control blood pressure, bladder function, bowel function, sexual function. So orthostatic hypotension, or OH, is a characteristic feature. And when your blood pressure drops when you stand up, you don't perfuse your brain. You don't get enough blood to your brain, and this results in fainting or syncope. When you don't have normal autonomic function of the urinary bladder, you lose control of your bladder or you retain urine. You may have severe constipation when the bowel is involved, or you may have erectile dysfunction in men when the autonomic function to sexual function is impaired. So these are the hallmarks of multiple system atrophy. There are a number of other features that we can see. For example, respiratory abnormalities, breathing problems. Now, obstructive sleep apnea is relatively common in the general population. And most of you have heard of this, where people need to use CPAP machines to sleep at night. This is more common in MSA, but certainly we wouldn't consider MSA in the average individual who presents with obstructive sleep apnea. On the other hand, patients with MSA may have the tendency to sigh and have deep breathing sighs, or they have something called stridor. Please listen to this. When the patient is breathing in, you hear the vocal cords pulling tight together, causing that stridorous sound. Abnormal postures of the neck and of the trunk are fairly common in this disorder, and this slide shows you what's called the Pisa sign, with the person leaning to one side, like the Leaning Tower of Pisa. The disproportionate tendency of the neck to pull forward or move forward, so-called anticollis, and the severe flexion of the trunk, so-called camptocormia, may all be seen. Now, all of these features can be seen in later Parkinson's disease, but they're more common in multiple system atrophy. Other features include what's called emotional incontinence, the tendency to involuntarily laugh or cry, sometimes without any emotional features associated with it. So the patient may not feel mirth or sadness and may still laugh or cry. Increased deep tendon reflexes when the doctor tests your reflexes. These may be pathologically increased. Change in blood flow to the skin may result in coldness and discoloration, motley discoloration of the feet and of the hands. And this feature, very important, rapid eye movement behavior disorder. When we dream in sleep and have rapid eye movement sleep, our brain has a normal mechanism to shut off the control of muscles. So we become what's called atonic. We lose control, or we lose muscle movement. And when you can move in your dreams, you can hurt yourself. You can injure your bed partner. You can fall out of bed. And REM behavior disorder looks like this. So this patient is asleep, goes into REM sleep, and starts to enact his dream. These can be very frightening dreams. The patient may fight and punch out and kick. And you can see how this might injure themselves and someone sleeping with them, including falling out of bed. REM behavior disorder may be an early manifestation even before all of the other features. So when patients are asymptomatic of the other features I've shown you. So a prodromal feature, so to speak, and I'll come to that in a minute. Features against the diagnosis. This is a disorder that typically begins earlier in adult life, and so after the age of 75, it's relatively much less common. And so, for example, if we see REM behavior disorder in an elderly individual, this is more commonly suggestive of Parkinson's disease or dementia with Lewy bodies, another synucleinopathy. I mentioned if Parkinsonian rest tremor is present, we think of Parkinson's disease and not typically MSA. When the peripheral nerves are involved and when you lose normal sensation and power of the hands and feet, we don't think of multiple system atrophy. When hallucinations or dementia are prominent, these are features that are not suggestive of multiple system atrophy, and these are far more common in Parkinson's disease or dementia with Lewy bodies. And I mentioned a strong family history is against the diagnosis. Unfortunately, this is a bad disease, and I really don't like to make the diagnosis because this affects, as I've told you, relatively young adults beginning around the age of 53, but with a fairly rapid progressive course requiring an aid to walking within 3 years, the use of a wheelchair by 5, unfortunately bedridden by 8, and death within 9 to 10 years of onset of symptoms. So it's a disease we really don't like to diagnose, and unfortunately results in very severe debility and early death. All the more reason that we need investment in this and breakthroughs to change that course. The timelines to milestones. Here's the age from 50 to 80. Parkinson's disease typically beginning around the age of 60 or late 50s, lasting for 15 to 20 years, with falls, residential care, cognitive disturbances occurring relatively late over the course. Another Parkinsonian disorder that can be mistaken for both Parkinson's disease and MSA is progressive supranuclear palsy. This is a disorder that begins later in life, usually in 60s and 70s, develops over a fairly short course like multiple system atrophy, and unfortunately death occurs within 10 years or less. And you see these milestones: cognitive dysfunction, falls, wheelchair use, dementia, urinary catheter, occurring over the course of the last half of the disease. In multiple system atrophy, on the other hand, as I've told you, the disease begins earlier in life, with some of these milestones tending to occur later in the disease rather than earlier. When autonomic dysfunction occurs early, patients suffer from the disease for a shorter course. So this is to death. So patients die earlier, the green line, compared to the later development of autonomic failure, like orthostatic hypotension, bladder problems, etc. Whereas if you have an early age of onset, under the age of 50, you tend to have a longer course, so you live longer with the disease than if you have an early or a late age of onset, I should say. Myself and a group from England at Queen Square described a small number of patients with a prolonged survival, and there were some helpful features. So here's again Parkinson's disease, the age and the disease duration. So Parkinson's disease beginning in the late 50s and lasting up to 20 years of disease course. MSA usually beginning in the mid 50s and lasting about 10 years or less. Whereas this prolonged survival form tends to begin earlier, and patients may live as long as the typical patient with Parkinson's disease. And one of the characteristic features that predicts this course, this line with the black dot at the top here, shows you that the development of orthostatic hypotension, that blood pressure falling when patients stand up, and the tendency to faint, is a late manifestation in patients with prolonged survival. So if it's early in the first few years, that tends to predict a shorter survival, but if it's delayed, patients may live considerably longer. This is a cartoon showing the brain cut in half sections. So here's the front of the brain, the back part of the brain, the cerebral cortex, the cerebellum, the back part, and the brainstem. And in the Parkinsonian form, MSAP, or the striatonigral degeneration form, the area of the brain called the striatum, the movement part of the brain, the nigra and the striatum are particularly affected, whereas in the cerebellar form, the MSAC, the olivopontocerebellar atrophy form, we see more pathology, greater involvement of the degeneration in the pons, the part of the brainstem, connected to the cerebellum far more than the striatum. And here are the regions that are more affected with autonomic failure, the various different regions in the brainstem. So as I've told you, MSA has these two major subtypes, Parkinson and cerebellum. In North Americans, Caucasians in North America and Europe, the Parkinsonian form predominates, whereas the cerebellar form accounts for about a fifth of patients. Whereas, as I've told you, in Asians, particularly Japan, it can be more of the reverse. There is some suggestion that the cerebellar form may have a more prolonged survival than the Parkinson form. And there's another form that's relatively uncommon where the substantia nigra, if I go back to this diagram, and I'll show you pictures of the pathology in a minute, the dopamine area, if that region is most affected and the other areas are minimally affected, patients may present with a Parkinson phenotype that may respond very well initially to levodopa and may have a somewhat more prolonged survival as well. Neuroimaging can be helpful in the diagnosis of Parkinson's disease. This slide shows you the magnetic resonance imaging features. When the Parkinsonian feature predominates, here is the striatum, and these arrows show this, mainly this white line that manifests or demonstrates the atrophy of the striatum, so loss of the putamen. And these MRI scans, this highlights the presence of iron deposited in this degenerated region. So that's very characteristic of the striatonigral form. Whereas the lower brain, so this is the upper basal ganglia, the motor parts of the brain. This is the posterior part, the cerebellum, with the pons and the cerebellum. And here is what's called the hot cross bun sign, this white cross suggesting the hot cross bun of the buns that are often eaten during Lent and Christianity. This white area here in a region called the middle cerebellar peduncle. And these white lines are indicative of loss of the substance of the cerebellum, indicating atrophy or degeneration in the cerebellum. So these are some of the hallmark features that the doctor looks for, suggesting the diagnosis of multiple system atrophy, the Parkinsonian and cerebellar forms. We can use something called apparent diffusion coefficient maps that are also helpful looking at the striatal changes in multiple system atrophy of the Parkinson type. We can also look at radionucleotide imaging, and I'll just quickly explain this. This is a cartoon of the neuron that I showed you before. Remember, the synuclein is in the synapse, helps package the dopamine for release into the synapse. The little yellow circles are the dopamine being released onto the postsynaptic neuron. So this is the presynaptic dopamine cell, the terminal, the synapse between the presynaptic neuron and the postsynaptic neuron. And these are the striatal neurons making up the postsynaptic neurons that have receptors for dopamine. So in Parkinson's disease, we see a loss of these presynaptic neurons. And here's a ligand that marks the terminal. This is for example, a dopamine transporter ligand, and these nice fat comma-shaped regions are seen in the normal controls. And in Parkinson's, we lose the back part or the lower part of the comma. That's the putamen. And in early Parkinson's, we see a progression to greater loss in later stage Parkinson's disease. Whereas when we mark the dopamine receptor with another ligand, in Parkinson's disease, before you get levodopa, these receptors are more avid. They increase their activity because they've lost dopamine. But then when we treat patients, they return to normal. So you see here, these receptors are retained. So it's a presynaptic loss with a postsynaptic retention of receptors. In multiple system atrophy, we lose both sides of the equation. We lose the dopamine cells, and even to a greater extent than in Parkinson's disease, whereas we also lose the postsynaptic. So here's the nigrostriatal. So you lose the striatal cells as well as the nigral cells. And so the ligands that mark the dopamine receptors are also lost. And this is much greater than in Parkinson's and even in other diseases like progressive supranuclear palsy that I mentioned earlier. What is the underlying pathology in multiple system atrophy? This is a brain that's sectioned, or brains that are sectioned halfway. So here's the outside of the brain. Here's the middle part of the brain. This is a patient with multiple system atrophy side by side with a normal control. And this is the striatum, the middle part, the basal ganglia. And you see here this dark discolored region that is shrunken compared to the normal non-discolored region. That's the striatum. Here's another cut of the striatum. You see a very different picture in the normal control. And here's another section, again, showing the loss of this normal putamen. So this is the MSA on the left side of your screen versus controls. If we look at the brainstem, the upper brainstem and the midbrain, here's the control again, showing the pigmented black substantia nigra, the normal pigmented dopamine cells. So you see pallor in the area where those cells are lost. And this is a slightly lower cut. This is the normal pigment, indicating the loss of the dopamine cells. And this is a cartoon showing the various different regions, the putamen, the substantia nigra, the pons, etc., all the areas that are lost in multiple system atrophy. Under the microscope, we see a loss of the nerve cells. So here you see all these little dots are what are called gliosis. These shouldn't be here. These are little astrocytes that are normally not present, and these change and make up the areas that are normally taken up by normal nerve cells. And when we stain for iron, we see this blue staining that shouldn't be there, indicating the iron deposition. Now, you remember that Papp and others described the oligodendroglial inclusion that really was the first hallmark that brought multiple system atrophy together as a single disorder and confirmed Graham and Oppenheimer's first impressions. And you see here with special staining the oligodendroglial inclusion. The oligodendrocyte is a normal cell that makes iron that is normally surrounding the axon. So here's the nerve, and the nerve projects the axon, and this myelin is the normal coating of the axon that allows rapid conduction along the axon, rapid electronic conduction. So this is like the coding of an electronic wire, and I've forgotten the term. I always forget the term that accounts for this coding that allows rapid electronic conduction. And so these oligodendrocytes make the myelin, and the pathology starts, we believe, in the oligodendroglial cell, and we don't know why that is. So if we stain for alpha-synuclein, remember that important protein, the oligodendroglial cell and the inclusions in these cells are stained very strongly for the protein alpha-synuclein, allowing us to see these far more readily. And so you see that in the normal state, the oligodendrocyte coats the myelin or makes the myelin coat, and in patients with multiple system atrophy, we see a degeneration of the nerve cell because these oligodendrocytes become sick and the inclusions are formed. But why that actually occurs, what are the pathways or steps that allow this process to occur with the subsequent death of nerve cells, is not entirely known. And hopefully we'll hear further lectures in this series today, bringing us up to date in some of the thinking as to why that occurs. And understanding that is going to be very important to the development of new therapies. How do we make a diagnosis of multiple system atrophy? Well, we use those clinical features that I've told you about and some of the radiological features to, as a composite to allow us to consider the diagnosis. And in 1999, a group of us got together to establish a consensus statement to allow us to make that diagnosis, combining certain domains of autonomic failure, Parkinsonism, cerebellar dysfunction with ataxia, and to a lesser extent, corticospinal tract involvement. And each of these had certain features that allowed us to reach criteria. There were exclusionary criteria on history, for example, a strong family history to suggest a genetic disorder, abnormalities on physical examination that wouldn't allow us to make a diagnosis of MSA, etc. And then the combination of all of this allowed us to make a diagnosis of possible or probable MSA on the basis of clinical features. The diagnosis of, excuse me, definite MSA was made solely on the basis of pathological changes, so after death. In 2008, a second consensus statement was made that just advanced these original criteria a little bit further, again, really being largely based on the presence of autonomic failure, levodopa, poorly responsive Parkinsonism, and ataxia, with new criteria for possible and probable MSA. And these criteria also highlighted additional features for possible MSA and the presence of red flags that suggested a diagnosis. Remember, I told you about respiratory size and cold hands and feet, etc., pathologic laughter and crying, as well as features that were against the diagnosis. Again, I told you about hallucinations or a strong family history, etc. Now, what's happened recently is that the International Parkinson and Movement Disorder Society, or MSA, has established a MSA criteria revision task force that started to work a couple of years ago in October of 2018. And over the course of the last 2 years, we've been working hard to develop new diagnostic criteria. And we were to have a meeting that really hammered this out in March of 2020, but unfortunately COVID-19 changed everything. And so we're still working on this, but are somewhat delayed in our endpoint. We do have some current proposals, and I'll share you this with you very briefly. We have criteria for neuropathologically established MSA, but now clinically established MSA, where we really think you can be very definitive about the diagnosis of this disorder, both based on Parkinsonism and cerebellar ataxia, all of which have the presence of autonomic failure. Clinically probable MSA, a criteria that is going to allow us to incorporate patients into clinical trials. I think that's going to be most important, encouraging the recruitment of patients that don't have to have a full house, but have to have enough features that we can be pretty sure of the diagnosis, and therefore then recruit these patients at an earlier stage into clinical trials, hopefully that might show the ability to slow the progression of the disease. And finally, a new diagnostic category, so-called prodromal MSA. Remember I told you about REM behavior disorder, for example, in the absence of the other clinical features, and maybe that will allow us to understand the disease earlier and give us better clues as to the nature of the disorder. So all of this is ongoing, and hopefully within the next 6 months, we'll see a final publication come from this task force. And one of the reasons for all of this work is to try to move the needle backwards. So not to have to make a diagnosis when the horse, for example, has left the barn. You can't close the barn door after the horse has bolted. So once the features are well established, it may be that the diagnosis is a bit too late to be able to make a big dent in the condition when we're using experimental therapies that could slow the progression. What we'd like to do is move the needle earlier in time. So get patients at the earliest stages, at a much earlier stage of severity, when they may just have certain biomarkers and very, very mild clinical features. And if we can make a diagnosis more accurately using experimental criteria that might be discussed in some of the lectures later today, maybe we'll be able to initiate experimental therapies that will change the course and prevent people from rapidly progressing into these more overt stages. So I'll stop at that point. I've tried to give you a sense of what the clinical features of MSA are, what the pathological features are that account for those clinical features, and how we make that diagnosis, and hopefully how we're going to see a change and an earlier diagnosis so that some of the treatments that you're going to hear about later today might come to fruition. So subsequent lectures are going to tell us how we treat now, and then hopefully how we're going to treat later when new research comes about. So I'll be available for a question and answer period later today, and thank you for your attention.